People love to love and hate Obamacare. It was a complicated, controversial, and complex act. One of the unintended consequences was that it increased total healthcare costs, exactly the opposite of what it was trying to do. In this video, I'll break down why after 15 years of Obamacare, healthcare costs are still increasing to the point that it's unaffordable for the vast majority of Americans. Let's dive in. Obamacare started the implementation train of what's called value-based care, and I have an entire playlist of several videos in my YouTube channel explaining the mechanics of value-based care. The central premise of value-based care is that the prevailing system for paying doctors, which is called fee-for-service, is the main culprit of runaway healthcare costs. In a fee-for-service system, doctors are paid for every single visit or procedure that they perform. And the thinking was, in this system, doctors are incentivized to do more because they get paid every single time they perform a service. And this bad incentive is the problem for higher healthcare costs. So according to Washington, D.C., the most elegant solution was to make doctors responsible for the total cost of care. And if doctors perform more procedures than the allotted budget that they were given, they'd have to pay back Medicare. And so the thinking was that doctors will avoid doing unnecessary tests and procedures. But the trillion-dollar question was, who's going to determine what's necessary and what's unnecessary? That is, who determines what the value of care is to people? Now, some of you may be thinking, this is ridiculous. I should be the one who should be defining because I'm the one receiving treatment, not the government or some private insurance company. Well, it gets worse. Keep watching. The system of value-based care was the brainchild of Michael Porter, which was published in a book called Redefining Healthcare in 2006. In the book, he defined value as outcomes divided by cost, or better outcomes at the same or lower cost. Now, the big assumption of value-based care was that it's going to decrease unnecessary and wasteful care that the insurance company today has to pay for, which in turn would then reduce the total cost of care. But like most centrally planned schemes, this scheme not only does not work, but it has had the exact opposite effect. So here's how the game is implemented. What the industry calls value-based care, in reality, is what's called a risk-based contract. Now, CMS, as part of these risk-based ACO contracts, gives a group of doctors a budget. If the group of doctors spend less than the budget, they can keep some of the difference. This is called shared savings. And if the group of doctors spend more than the budget, guess what? They have to pay CMS back. This is called shared risk. Let's first start with the so-called budget that doctors get under these risk-based contracts. Sorry, I meant to say value-based contracts. This budget is also called the benchmark. Now, this benchmark is a prediction of what the healthcare costs are going to be over the next year. And the prediction is based on, guess what? Data modeling. And like all data modeling, you can modify the output based on what you feed into these models. That is, you can increase or decrease the budget based on the inputs. So what are some of the inputs that you can modify to manipulate these benchmarks? Well, first, you can make the patients look a lot sicker by modifying what's called HCC codes. Next, since benchmarks depend on historical spending, you could buy some practices in a region that has very high spending. Or you can just rearrange all the healthcare business tax IDs that have different historical patient costs to optimize benchmarks. And if that's not enough, you can move doctors in and out of different contracts depending on their patient panel that have higher or lower costs. The point that I'm trying to make is that the insurance math is very complicated and there are a lot of ways to adjust the benchmark or the budget. And if you can manipulate and increase the benchmark, you don't have to provide better care. You can still make a lot of profits. And guess what? Your favorite solo doctor does not have a math wizard in his back office to do all of these fancy actual calculations. And as we'll see later, that also would not make a difference. So what happens to your local small practice? Well, they cannot participate in any of these contracts. CMS blames them, penalizes them, till they either go bankrupt or they sell out to large organizations. So essentially, these value or risk-based contracts, all they did was shift the financial burden from the insurance company to the small medical practice. And insurance is a scale game. You need a lot of patients to spread the risk of a few high-cost patients. So for example, in my practice, if I have a few cancer and transplant patients that rack up hundreds of thousands of dollars in costs, I can't spread that risk between my other patients. The math just doesn't work. What the math requires is scale. That is, a lot of patients under a single risk-based contract to function as a mini insurance company. And for this, you need different actors in the healthcare space, such as physicians, surgery centers, hospital systems, etc., to come under one umbrella. That is, to consolidate. Before we talk about consolidation, let's do a quick recap of everything we discussed up until now. Value-based care in reality is implemented as what's called a risk-based contract. And a risk-based contract turns doctors into mini insurance companies, making them responsible for the total cost of care. That is, a budget. This budget or benchmark under these risk-based contracts, they're predictors of the future cost of care, and they can be easily manipulated based on the inputs into the data models. And to function as an insurance company, that requires scale. This math does not work out for small practices, as they cannot survive and they often sell out, leading to consolidation in the marketplace. Now, some of you may be thinking, why does it matter if my doctor has his or her own practice or is employed by a large organization? First, there's plenty of data to show that small practices often provide much better care than large organizations. Second, as we'll see later, small practices are cheaper and provide competition to these large systems, which has broad economic effects. Okay, so let's talk about consolidation in healthcare. Now, the process of consolidation started way before value-based care even arrived on the scene. This was a product of changing the fee schedule from what was called the usual and customary model, to the current centrally planned system in which physicians are paid based on CPT codes that we bill every time we see the patient. Now, over time, Medicare and even private insurance companies, they've ratcheted down what we get paid for these CPT codes. And this put a lot of financial pressure on most medical practices. The government and private insurance companies, they added to this financial pressure by mandating a lot of compliance measures, including buying electronic health records for tens of thousands of dollars and spending money on collecting and submitting on quality measures. Value-based care in the form of risk-based contracts, however, that's a step change, as mathematically it's just not possible to participate in these contracts without having a large patient population to spread the risk of a few high-cost patients. Now, when I think about consolidation, I divide it into hard and soft consolidation. Examples of hard consolidation include employing physicians by buying their practice, a merger and acquisition between hospital systems, or a vertical integration between health insurance companies and doctors' practices, or private equity roll-ups where a private equity company buys a ton of medical practices in a local area to create a local monopoly. Examples of soft consolidation include accountable care organization networks or ACO networks of independent physicians, the most prominent example of which is Aledade or Privia. One of the challenges with soft consolidation with independent physicians is that these ACO networks still need a lot of money. That is, they need financing from someone. And this financing can come from either a venture capital partner, traditional investor, private equity, or in partnership with a hospital system or a health plan. Which means that eventually when the ACO does not perform, these physicians will end up being absorbed by whoever the investment partner is. And I discussed some of these mechanics in my value-based care simulation model, which you can find on vbcsim.pcplens.com and in some of my prior YouTube videos. One of the advantages of ACO networks is that it allows small practices to remain independent. And as I mentioned earlier, small practices often provide better and cheaper care. Now, with this background of how value-based care is implemented as risk-based contracts in real life and how it leads to consolidation, let's see how all of this comes together to raise the total cost of care in the United States. To understand the system, the first thing that we need to do is we need to separate out saving money on a single contract versus saving money on the entire healthcare system. Most ACOs, including the poster child of value-based care, Aledade, predominantly saves money on a single contract, that is, Medicare Shared Savings or other Medicare ACO programs. And saying that ACO saves money in Medicare contracts is kind of complicated. What the ACOs do, or they did, was they beat the benchmark. And as we discussed earlier, you can actually manipulate the benchmark. So the correct answer over here is we actually don't know if we saved any money in any of these contracts. Our guess is that we did, but it is very hard to prove since there's no good counterfactual. That is, what would have happened if the ACO did not participate in the contract? But that was just one contract. Remember, the insurance companies require scale. So in order to succeed on that one contract, consolidation increases in the region. That, my friends, is what causes most of the problems. The most immediate effect generally is that your favorite independent doctor will probably sell his or her practice to a large organization. And then it becomes harder for you to get an appointment with him or her. And if the buyer is a large health system, it's probably a nonprofit and already has a few hospitals under its belt. After buying up all the local practices, this hospital system is even larger and has more negotiating leverage because there's no competition left. This then has several unintended consequences. First, your local private doctor used to pay a lot of taxes. The nonprofit does not. The state just lost money. Second, these practices are now classified as hospital outpatient departments. This means that the hospital system now gets a hospital facility fee, which is approximately 20 to 30% more for the exact same service that your independent doctor was giving you. Then the hospitals start nudging the newly acquired primary care physicians to refer patients to their employed specialists. So your blood pressure, your diabetes, that could have been handled by a primary care physician. Guess what? You're now seeing a cardiologist and an endocrinologist in addition to your primary care physician. So instead of having one copay or deductible, you now have 3. And it's higher because you're also paying a hospital facility fee. And also, since the large healthcare organization has more power in the marketplace, this large organization the next year goes back to the private insurance company and negotiates a higher rate for the exact same service. The insurance company now has no choice as there's no competition left in the marketplace. So it gives the hospital systems the rate that the hospital system asked for. But in return, it raises your premiums. So now not only are you paying more at the doctor's office, your premiums also went up. And not only did your premiums go up, your employer portion of your premiums also go up. What this means is that the company that you work for now, they cannot give you a raise next year. Also, they have to raise prices on the products that they sell. For example, did you know that Starbucks spends more money on healthcare on their employees than they spend on buying coffee beans? In practice, these higher costs in the commercial sector end up leaving you with less money in your pocket and higher prices for the products that you buy. Who knew competition from local independent doctors was good for the entire economy? Okay, so now let's switch gears and talk about Medicare Advantage. These Medicare Advantage plans, they take these risk-based contracts to an extreme, especially with benchmark manipulation to inflate the predicted budget, pocketing billions of dollars from the Medicare fund, pushing it faster and faster towards insolvency. In fact, every single major Medicare Advantage plan has been fined by the government for fraudulent billing to inflate the benchmarks. And lastly, there's Medicaid. Large hospital systems love to promote how much they lose money on Medicaid and charity care. Guess what? First of all, many of these nonprofit hospitals, they don't pay taxes. Small practices have to pay taxes. Next, all of these hospitals get supplemental payments, each hidden behind jargon acronyms such as DSH, which is disproportionate hospital share payments, UPL, which is upper limit payments, SDP, which are state directive payments, 1115 waivers, and the 340B drug waiver program. These programs can be extremely lucrative and can easily add another 25 to 40% in revenue to these hospital systems. And your small practice doc is not eligible for any of these government programs. So guess what? Your state was saving a lot of money when the independent practices were taking care of Medicaid patients. With consolidation, now the state is paying all of these extra dollars from these supplemental programs to these large consolidated health systems. The state budget blows up, they have a budget deficit, and they now either have to raise taxes or they have to cut other essential services. So you can see over time, even though the ACO may save money in a single contract, a consolidated organization in the region will increase the total healthcare costs, which will lead to higher premiums, faster Medicare insolvency, and blowing up state budgets and your budget too. And as healthcare costs keep going up, what's repeated in the media? Doctors are the problem. Fee-for-service is the problem. All doctors need to be contained within a value-based care contract. Net result? Medicaid tightens the rule, private insurers squeeze the independent docs because they can't squeeze the large consolidated health systems. And consolidation keeps increasing. With so much consolidation in the marketplace, we now have entities called payviders. That is a single company that is both an insurance company and a provider, which is why they're called payvider. They handle both payments and patient care. The two biggest examples of payviders are United Healthcare with its Optum arm and CVS Aetna. And as consolidation keeps increasing, over time we will have only 1 to 2 payviders in a region, or maybe even nationally. So the question that I'm going to leave you with is, do we want a handful of organizations to define, decide, and deliver healthcare to the entire United States while the cost of healthcare keeps increasing every year? Is this what we want for the future of our healthcare? With that, take care and goodbye.